like to introduce our facilitator, John Petrozzi, who is the Central and Eastern Sydney Allied Health Network Chair and practicing chiropractitioner.
Thanks, Lauren, appreciate that. And good evening, everybody, and thanks for making time tonight to learn more about the quality and safety standards, which will be affecting us all in our allied health practices. And I want to thank Central and Eastern Sydney Primary Health Network for putting on tonight's webinar, and welcome to all the members of Central and Eastern Sydney Allied Health Network. I want to introduce tonight's speaker, which is Margaret Banks. Margaret has been Senior Program Director with the Australian Commission on Safety and Quality in Healthcare since 2006. In this time, Margaret has worked with stakeholders, consumers and jurisdictions on the development of a range of safety and quality standards, including the National Safety and Quality Primary and Community Healthcare Standards, which we'll be speaking about tonight. This is Australia's first nationally consistent safety and quality standards developed specifically for our sector. Margaret is a physiotherapist by background and has worked as an executive across a number of government agencies with a focus on workforce and driving improvements in patient safety through the implementation of national standards. Thank you, Margaret.
Thanks so much for the introduction, John. And can I also recognise the Aboriginal and Torres Strait Islander peoples that of the lands on which we're located tonight. I'm on Cammeraygal country of the Eora Nation. I have a presentation, so I'm going to share my slides with you. And I hope you're able to see all of those.
Yes, we can, Margaret. Thank you.
Lovely. Thanks so much. So today, what we're going to be talking about, and I hope by the end of this session, you'll be able to summarise the things that the standards and the concepts that have made up the National Safety and Quality Primary and Community Healthcare Standards, and identify for your practice and for other primary care practices the impact of those on care. So we're going to talk about the Commission so that you have a bit of an understanding, so you've got some context, why these standards particularly, and then talk about the structure of the community's care standards, primary and community care standards. We'll get how you can start putting those in place, accreditation and what that might look like, and then have the opportunity to have any discussion. And then we've got a slide on where you might be able to go for more information should you need it. So the Australian Commission on Safety and Quality was established in 2006. It was the fourth organisation in iteration of its formation, a government body with a function to lead and coordinate nationally in safety and quality in healthcare across all sectors, not as our previous body was just in the public health acute sector. We operate under the National Health Reform Act, and the National Health Reform Act was implemented in 2011. We're funded jointly by state and territory governments and the Commonwealth Government, and therefore while we report under a national banner, we certainly have an interest in all states and territories. Our role is specified in the legislation to formulate standards relating to safety and quality, to promote, support and encourage safety and quality activities, and those are broad in relation to the collection and reporting of safety and quality information, but really any matter that relates to safety and quality in health services. We also have a responsibility to formulate national safety and national accreditation schemes, both for health services and to address safety and quality matters. And we collect, analyse, interpret and disseminate information relating to safety and quality. In terms of the safety and quality standards, these are only one set of the many sets that we develop and administer. So in the National Safety and Quality Standards group, there is the health service standards, which apply to the acute sector. We've recently released the digital mental health standards, which are being applied, and the accreditation will start very soon for those, and the primary and community healthcare standards. We also run a series of accreditation schemes. So the Australian Health Service Safety and Quality Accreditation Scheme, under which these standards apply, and the acute sector standards, but also standards for multi-purpose services. We have the National General Practice Accreditation Scheme, which uses the RACGP standards, 5th edition, for general practitioners. We have the Diagnostic Imaging Accreditation Scheme and the pathology, so it is the National Pathology Accreditation Advisory Committee standards. Both of the administration and the development of standards has recently moved over to the Commission. And so now we've got responsibility for those schemes as well. Why have a national set of standards? Why not have everybody have their own, or states and territories develop them? When you think about standards, they are incredibly expensive to develop. They take a lot of time to implement. And so when you're looking at a set of standards, what are you trying to achieve? It's an explicit statement of the expected quality that's being provided to a consumer. And by stating that, and the way that the standards are written, we've said this is not just a minimum, it's what is expected, because a floor level may well be below that. And people say that's not where our standards are set. But in the context, this is what consumers can expect. They can expect that people will wash their hands. They expect that when they receive care, that they will be safe. It describes common features that are all about safe and high quality care, and they're based on evidence and best practice. So the Commission spends a lot of time reviewing the evidence or developing the evidence where it's not available, so that the standards that we put out actually have a strong foundation in the evidence or in practice. We also try and address safety and quality issues that are common. So not everything that is a safety and quality issue ends up in a standard. There's lots of other mechanisms, and standards can sometimes be a blunt instrument. They work on a systems level, not on clinical level. So what we want to do is make sure that the strategies that we put in place are going to make a difference at the systems level. And we work where there's variation, because we know that where you standardise, you get better outcomes. Where you use evidence-based practice, you get better outcomes. So in those areas that affect a large number of people, where there's variation and we've got evidence-based strategies, we know we can make a difference to care that's provided. We use a risk-based approach, because it is not, you're never going to write a set of standards that will apply in the same way to every service. Some will be every practice, some will be complex and large and have, a higher level patients with more allied health components to it. Others will be very simple, with a single provider having a very limited scope of practice. And so you need to have a set of standards that can apply flexibly wherever they are applied. So we say what needs to happen, not how it needs to happen. And the how is determined by the risk. So an organisation with a significant risk will have more strategies, more complex strategies, and spend more time on minimising that risk than someone where the risk is very low. And the standards provide a framework for assessment. So by having a measure of what should happen, what we've got now is a way of testing whether that's actually in place. So why implement national standards? Well, because it is a public declaration that you're prepared to make an effort to ensure safety and quality care is delivered and seen to be delivered in your organisation. It's also sometimes used as a way of saying, look, we need to meet standards, so therefore we need to do the training or update the equipment or make a change in the practice. So it's a lever to drive safety and quality practice. It's also a tool for quality improvement. It sets out the structure for you and it describes in some places the monitoring that needs to be done. And so what you're doing is setting up a framework for ongoing quality improvement. And all of that will lead to better patient outcomes, increased confidence and trust in the service that you provide, and ways of standardising, which leads again to better outcomes and better service provision. When we look at the standards development, it hasn't taken 5 minutes. Let me tell you, it's been a very long journey to get where we are. 2015, we did literature reviews. What we did was look at the safety issues that were evident in primary care. We wanted to see what the evidence was around the strength of the evidence around the strategies that are in place, to see if we could identify those areas that were common and we had evidence for. We put out a public consultation in 2018 and then a second one in 2019, trying to understand from people what it is that they thought was important in a set of standards. There was a draft set of standards produced in 2020 that went out for public consultation in 2021. And then there was the development of resources and support and the launch of the standards. So this had a long gestation. Now, that 6-year period is exactly the same period that it took us to write the first set of acute care standards, because we went through that same process of iterative trying to get to understand, you said this, is this what you meant? And by going back out to the sector on multiple times, I think we've been able to get a set of standards that make sense and resonate with primary care. So when you look at the standards, they follow the same formula as any of the other standards that we write. They've always got the first two standards that give you the clinical governance framework in an organisation. Now, the Commission's done multiple reviews of systems failures and public harm to patients. And it's evident to us that clinical governance is one of those areas where it is incredibly important for systems to be in place. It is the foundation of good safety and quality in an organisation. And a clinical governance framework has 5 elements. The first one is leadership, because we know from the literature that safety and quality requires leadership to be effective. Then we have processes, people, environment, so that the location that you provide care is safe, and then consumers, and partnering with consumers being one of those 5 elements. And if you took the first 2 standards and implemented them, you would have in your organisation a robust clinical governance framework. And then the third standard, or the other standards in a set of standards, relate specifically to the service type, and it is the clinical or models of care standard. In this case, clinical safety standard, but it really describes those things that are specific to primary and community care that need to be addressed. These standards have 65 actions, which is about a third of the size of the acute care sector, and about the same size as digital mental health. So when you look at it and you think about the sort of actions that you would want to take, and the things that you would want to play in place in a primary care compared to an acute service, then clearly the acute service has a lot more risks and a lot more complex concerns. So you want a whole stack of additional structures around it. So what we've tried to do is build a set of standards that are appropriate to the structure and service type that we have in primary care. Of those 65, a possible 10 might not apply in your setting. So, for example, if your service does not have anything related to medications, then those actions wouldn't apply. Every standard has basically the same structure. We start off with a definition about what the standard is about. We say what it is intended to achieve. So with the clinical governance standard, it's to implement a clinical governance framework. We have explanatory notes which talk to the intent and the way that it might apply. we have a consumer statement which says, why are we doing this? And for everything that we do, it's about how do we improve care for the patient, and that we always try and put the consumer, the client, at the center of the things that we do. And that's how we draft up a set of standards. It's what would that mean for a consumer, and how can a consumer be involved? And then we have what we call items, which are really just headings, a way of navigating a set of standards very quickly, because you know basically the headings. And then the actions state what is required. And it is a what has to happen, not how it has to happen. Because by saying what needs to be achieved, you can determine in your own organisation for the service that you're providing how you will achieve it. And so large and complex organisations will have a much more complicated how than smaller organisations. If we look at the clinical governance standards specifically, it's got 25 actions and it covers the areas listed there. So culture of safety and quality, this is about leadership in the organisation. It's about having a clinical governance framework. Policies and procedures, because we know they are the foundation. It says to your organisation what you have to do and how you have to do it. Then it has a whole series of processes that ensure that when things go wrong, there's mechanisms for picking that up, monitoring it and improving it. So incident management, feedback, complaints, and really the thing that I don't see there is risk management. So it's about understanding the risks that your organisation or your practice presents, as well as the patients present, and how you're going to minimise those. It then thinks about your patient population. So who do you provide care to and what's their greatest risk? So if your patient population is over 65 with lots of comorbidities, that will be very different to a practice that's looking at doing sports medicine with young, reasonably fit, just injured people. It talks about the skills and qualifications of the providers of the health service, of the healthcare, because making sure that they are qualified to do the role, they understand what role they have and what their safety and quality obligations are within an organisation, means then that you can hold them accountable for those, but also they know what it is that they're expected to do. Using evidence-based care and providing that care in an environment that's safe. Now, that does not have to mean that you have a sterile environment, particularly for those services that might provide it as a mobile service or in other people's homes. It's about making the environment where you provide care as safe as is possible by assessing the risks that present. The partner with consumer standard is much smaller, but it is incredibly important. The evidence shows that the more a consumer is involved in the care, the more likely they are to comply and to participate and to engage in and make better informed decisions about their care. So the actions in the partner with consumer standard are about how people can be partners in their own care, make decisions about their own care to the level they want. It's about understanding my healthcare rights. There's a health charter, and that describes the rights of a person in a healthcare setting. And this is really important because understanding that they have rights means that they can, ask for information, be given feedback, provide feedback to your organisation. Communication and information is really about how you share information. So if you provide information to consumers, it's in a format that they can understand, or in a language that they can understand, and it's information that's relevant to their care. And incorporating their views in how you design your service. So asking them about privacy, about design of your waiting areas, about the way your recall system works, about the information that's provided about after hours service. All of those things would be, you could ask your consumers about, and to see if they had feedback about the way it's happening now. The third standard is the clinical safety standard, and this is the one that relates specifically to primary care. It talks about the issues for preventing and controlling infections in a practice setting, medication safety, comprehensive care, that care that brings together and operationalizes the partner of the consumer. So how do you assess, screen, assess, plan for care, plan for discharge, and then recognising and responding to serious deterioration to minimise harm. So those patients that start to deteriorate, how do you identify it, escalate it, and respond to that care? So they're the actions, and some of these actions are the ones which may not be applicable in every setting. If you're just getting started, then where to go first is to actually get a copy of the standards. They're on the Commission's website. There's a copy of the front cover there. Reading the standards and working your way through the information that's provided in that, in terms of the intent and the explanation, will get you on the road. There's some shorter resources, some fact sheets that are there. I think the next thing is to reflect on your current practice, because it is very likely that you are doing a lot of what's required of the standards. What we found when we introduced the standards in the acute sector was largely it was happening, but it wasn't documented well. And because it wasn't documented well, it was no way of knowing whether you were improving or if, sharing that information across a number of people. So reflect on what's happening now is an important first step. Identify the gaps and areas for improvement. So if you're not doing it, then what do you have to do to be able to show that you're complying? And then make some changes to address those gaps. So really that's the stepwise process that you would take to be able to put this in place. Now, this is tricky because organisations in primary care and community have very different structures to an acute service, where there's a large structure with lots of people. In large organisations and community services that are run by LHDs are a good example. They may very well have every level, governing bodies that sit over a whole set of different service types, managers and a provider. But as you work up, you may find that in some services there is only one person who acts as the person responsible for the governance of an organisation, that manages the organisation and provides care. So in each of these cases, we recognise that you will have different hats to put on for each one of these functions, but you do need to think about your organisation, your practice, in terms of these different functions, because each one of them has a safety and quality responsibility. If you're looking for help, the Commission has got fact sheets. We have developed or are developing an implementation guide that will walk you through the sort of things, the strategies that you would put in place. It's got a series of reflective questions to help you think about, well, what am I doing in this space for this? It will list additional resources, and it'll be available online. So it will link to other resources where they're available to you. We have an advice centre. You can phone or email. They will give you information. We try and get a response within 3 days. If it's not too tricky, if it is, then and it's technical, we'll go out to experts to try and get that advice for you, so that what the information we give you is actually useful. And we can certainly link up with other organisations so that the information is useful to you. So let's talk then about accreditation, because the standards are the most important component of this. They're like the course you do at university, the 12 months, take a long time, a lot of different components to it. And it's where you do the learning and the changing and the development of your skills. Same in your organisation. It's where you make change and you improve care for your patients. But as like the university course where you have to have a test, the accreditation process is sort of that exam at the end of a year. It takes a very little bit of time. There's no way that that assessment can assess everything you've learned or done, but it is a way of verifying that standards are being complied. It's an independent assessment process that recognises compliance. In the case of the primary and community healthcare standards, it'll start later this year or early next year. It's voluntary. We don't expect that organisations will be made to do it, but it is possible. So if under a regulatory structure or under a contract, you may be asked to implement the primary and community health standards. Certainly that has been the case with other sets of standards that have been we've developed. And the assessments themselves will be conducted by agencies that have been through a process to verify that they're fit and proper organisations and that they comply with the way that the primary and community care standards should be assessed. In this way, it doesn't matter which agency you sign up with, they will all assess you in the same sort of way, using the same methodology. So what will assessment look like? What we've done is we've tried to recognise that for some organisations, and LHDs are a good example, they're going to have been complying with standards that are much bigger and more complex, were designed for the acute sector for decades, and so are going to be well across the language and the structures of accreditation. So they'll probably go in at stage 4 and just go under a regular assessment process. But some organisations that want to be accredited have never been accredited before. So it's a whole new language and process that they're getting to grips with. So in stage 1, we're saying that you can do a desktop assessment. It's really a document review, a way of helping you get your structures and processes in place. So by the time you undertake some sort of on-site or virtual assessment, that you will have those foundational documents available. If you do a desktop, you can do it it will apply every 2 years, but you can only do it for 2 cycles. So you can't just stay on a desktop forever. That's because a desktop assessment looks at documents. Documents tell you what should happen, not what actually is happening. So the fact that you've got a policy doesn't necessarily mean that you're applying it. And that's where the virtual or the on-site assessment would come in. Or interviews. So the observation and interviews may be done virtually. Once you move to an assessment where you actually have a virtual assessment, an on-site assessment, you don't have to do it so often. So it's every 3 years, and you could stay on that for, an extended period of time. One cycle for health services involved in physical examination, therapies or procedures, otherwise unlimited. So those organisations, practices that are providing counselling, for example, might stay there and not move on. Others would move on to stage 3, where there is a desktop assessment and an on-site component of the assessment. Again, that's a 3-year cycle, and then you could stay there forever. The last in stage 4 is in relation to the way the assessment's done, and that's at short notice. And the acute sector is just gearing up because we're going to make it mandatory for the acute sector to do assessments at short notice. Now, while that seems like punitive and it's quite scary for organisations to be thinking that's the direction they're going to go, for most organisations that have made the move, they say that it reduces the pressure substantially and they'll never go back. So we think it's a better way, a more rigorous way of assessing, and it also will be a lot less resource intense going forward. But you can see that we've tried to work through it so that it doesn't matter which stage you're at, there is a way of entering and developing the skills and understanding and the systems so that you can meet the requirements of accreditation. We've got more information on the Commission's website. We can certainly provide you with more information through newsletters and further information. And Kim Packham, who unfortunately is not with you tonight, is the manager of these standards and their implementation, and I'm sure she'd be happy to provide any information going forward. So, John, that's what I had to say today. I'm happy to take any questions.
Thanks, Margaret. That was a full discussion on the standards. Thank you very much for explaining all that to us. Do these standards apply to general practice?
No, they don't. General practitioners are assessed under the RACGP standards. And the reason for that is that it's linked to the different in funding programs, PIP and WIP. And so and that will continue. But what we're doing is we're working with RACGP to align the two sets of standards. So there's consistency in the way that they're applied. So no matter where a consumer accesses care, they can expect to receive the same level of care. Okay,
well, that's great. And for the participants watching and listening tonight, there's a Q&A box at the bottom. If you can just lodge your questions in that Q&A box, that'll make it easier for us to get your questions across to Margaret. Margaret, I've got a question in regards to if you had your practice and allied health practice in the community and you didn't really have any standards documented, where would you start?
Look, I think if you've done nothing, the first thing you do is you read the standards. You need to understand what's intended for you to do. The standards are written in language that we hope most people can understand. We've got glossaries if you don't, and we have fact sheets to explain specific components of it. So read the standards and say, am I doing it now? If I am, how am I doing it? And if I'm doing it, how am I documenting it? Because that's the stepwise. So yes, we do things in a standard way around the admission of or the entry into our practice of a new patient. How do I document it? How do I know that? Do I know if it's complete? So do we routinely check to make sure that that process is completed? So do I audit it? And if I find that there's a problem, what's my process for making sure that in fact we try and follow up so that we do improve. So we collect all that information that we actually need to be able to provide care. So and then it's about, well, yes, we collected, but what do we do with it? And we've got to think about what's the strategy we put in place to make the changes we need. And start with bite-sized pieces. You don't have to do it all at once. You know, this is a journey, and pick the things that present the greatest risk. And always start by thinking what's the risk here for people and the organisation, for the practice, and then and tackle those, because if you start to minimise those big risks, then you improve your overall practice straight away. That's
great. And what sort of timeline can people give themselves for implementing these standards?
Look, it's going to vary enormously. Those practices that have been community services that have been complying with the national standards are going to breeze it in. Honestly, they're not going to need time at all. New practices that have really, this is the first time they've looked at a set of standards, it may take them 6 or 12 months to get their head around it. And that's fine too.
Great. There's a question here, Margaret. Is there a cost involved with accessing these assessments?
Yeah, look, there is for the accreditation part. There's not for the implementation part. So you can get the standards off the website. They're available. All of the resources will be there. It's the accreditation, the assessment part. And the desktop assessment is going to be a lot cheaper because it doesn't involve people participating and viewing. Virtual assessments are cheaper than on-site assessments because that involves travel. So yes, there is a cost, but we know that safe care is effective and has a lot of cost benefits in terms of a business. So if you're providing care that's safe and you know it's safe because you've been assessed by an external set of eyes, then you've also going to improve the effectiveness of your business.
That's great advice. And when it comes to accreditation, will the accredited agencies be on the Commission's website for people to find?
Yeah, any approved agency, any agency that's eligible to assess will be listed with their contact details. And then it's up to practices to talk to those agencies to find out which one fits best with their way of working and the way and you know, their culture.
Great. Another question, how will these new standards work in conjunction with the community pharmacies who already have a process of accreditation in place? Will those standards go?
No, community pharmacy standards won't go, but we've also worked with them so we can align those standards and our standards. So for the Commission, while we believe that the national standards that we've developed should sit at the core of everything that happens, what we've tried to do is where particular organisations own the standards, that they align them and the components of the national standards sit either within them or they use it and add on to it. So the idea would be that you wouldn't have to duplicate, because that makes no sense. We're not here to create compliance burdens. What we're trying to do is have, for the whole system, a consistent level of safety and quality. It doesn't matter where you as a patient go and get that care.
Great, thank you. Another question, if an organisation is already registered with the NDIS Commission, do you know if there are many differences between these two sets of standards?
Yeah, NDIS standard and ours are very different, and that's a place we haven't been successful yet in trying to get a consistency. We have got some formal processes underway, and it is intended that we try and align them as much as possible. We do know that this is a sector that has a very big NDIS accreditation process, and we're trying very hard to minimise that. We've certainly mapped it to see where the overlaps are, but aligning it or making it mutually inclusive is really the next step for us.
And like you said, it's not trying to overburden the sector at all. It's trying to align what can be aligned and for the outcome of improved safety and quality.
That's right.
Another question, Margaret, will there be funding to help allied health clinics to get accreditation? Looking at quotes for accreditation stage 1, a desktop audit is $2,000. And looking at on-site audit stage 3, that will be around $4,000. Combining this with also NDIS audits, which happen three yearly, this becomes quite expensive.
Yeah, look, they're big numbers. I'm surprised that they're that high. Certainly when the dental practices did it, it was well under $1,000 for their desktop assessment. So I'm surprised that they're quoting those numbers that high. The bottom line is there funding available? Not that I'm aware of. It is there no government funds that I'm aware as like a program that sits with general practice, but it may come as a result of expected, you know, if there's contracted funding. You know, PHNs and commissioning may be one place that it does in fact come under a contract. But no, not that I'm aware of at this stage.
Okay, I certainly know there's the GPs receive, is it quality improvement program payments or PIP payments? Is that right?
That's right.
I wonder if that would be something that gets introduced to allied health practice in the future. I hope so.
Yeah, look, it'd be good, but I think that the Commonwealth, that program is in the billions. I don't see the Commonwealth being able to or willing to fund something that is at that rate. But that's not something that the Commission would enter into. I think that would be an industry advocacy process.
Yes, yeah. Another question, what promotion is taking place in the public to help the general population recognise the accredited practices and really value the standards and to choose the accredited practice over non-accredited?
Yeah, look, with the digital mental health, how we're doing it at the moment is we're developing what we're calling electronic badges, which, you know, identify practices as well as certificates, you know, hard certificates that you can put up. There's the opportunity to establish registers so that people can go on and search and say, is this practice accredited? We certainly think that that's possible. We also spend a lot of time with consumers trying to increase an understanding and awareness of accreditation. That's why we develop consumer-specific resources about the standards and about accreditation so that they better understand what's intended. And we have got an extraordinary reach into consumer land with the Charter of Rights by you know, leveraging off those areas where people are most interested, which is the Charter. We are starting to make a difference in terms of people understanding that if you want the Charter applied, then they've got to be an accredited practice.
Okay. There's another question here just in regards to payments for assessments, which I think you've already answered. We're getting close to the end. If you've got any more questions, if you can pop them please into the Q&A tab at the bottom. I've just got another question I've written down here. Where can allied health practitioners keep up to date with the Commission's new updates and things?
So on our website, we have a news section. Always the website will give you the latest set of resources. You can sign up and we can email you. There's a range of different services that we provide. So each week on Monday, there's On the Radar, which summarises all the safety and quality literature that's recently been released, which might be of interest to people. That'll also tell you when new resources that are developed by the Commission are released. If you go on the website onto the accreditation pages, there's always at the bottom of the standards page something that says Our News, and you'll find out what's been released. Or if you just want to ask somebody, the Advice Centre is the best way. They'll be able to answer you directly or send you an email straight back.
Excellent. Thanks, Margaret. Margaret, there are no more questions, and we've come to the end of our 45 minutes. I really appreciate you speaking to us all about the new standards and sort of demystifying a few things that maybe some of us had concerns about, and also mapping out the future that the better care and safer care that we provide, the healthier our community will be, and the safer our practices will be also.